It's great to see all of you here tonight for the 5th in the Leading Voices in Public Health lecture series for this academic year. I do want to remind all of you to get a copy of the book, Moments in Leadership, which has been provided tonight by the Pfizer Corporation at no cost. The reason we're handing it out tonight is that there is in fact a chapter that features our speaker this evening in here, and we thought you'd enjoy it, and it's a new book that reflects some issues in public health. Also for the healthcare professionals in the audience, I'm supposed to tell you that you may get up to 1 hour of CME credit, and there is no anticipated conflict of interest. Dr. Lurie does not benefit financially from poverty and disparities as they exist in the United States. The issue that we're talking about tonight, health disparities, is really a very, very important issue. It's one that as you talk about health in the U.S., it perpetually comes up to the forefront. What are we going to do about this issue of inequality as it exists across the health outcome spectrum in our country? It's so much a part of the dialogue today that we tend to forget that as recently as 10 to 15 years ago, it was not part of the dialogue. One of the reasons it is so important today is because it became one of the two overarching goals of Healthy People 2010. One was to add years and quality of healthy life, and the other was to eliminate health disparities. Eliminate health disparities. And one of the reasons that it is in Healthy People is because Dr. Lurie was the Principal Deputy Assistant Secretary of Health at the time and was overseeing the development of that document. Really, in the course of 15 years, Dr. Lurie has not only brought it to the national attention, but has become the national and international expert in health disparities. You can read her bio on the handout sheet. I'm not going to go into it except to say that we are really fortunate this evening to have with us a true leading voice in public health. Please join me in welcoming Dr. Nicole Lurie.
Thanks so much. It's really a pleasure to be here, and it's been wonderful to reconnect with Dean Wyckoff, who didn't tell you the other part of this, but he was my partner in crime in the Office of Health Promotion and Disease Prevention when we launched Healthy People. So he played no small role in any of that either. Rather than just spend a lot of time talking to you about the state of disparities, I thought I would really try to frame some of the issues in a broader context. And so titled my talk, Quality and Inequality in Health and Health Care, but really also want to focus a substantial portion on what we know from emerging science now. Because that's something that's very different than it was when I started in this field, however many years ago it was. I think we know, though, and need no reminder, that inequalities are absolutely ubiquitous. It doesn't matter whether we're talking about rural Appalachia or whether we're talking about urban Philadelphia, which is where I trained. And I think that, what we know about these things are that the causes of health disparities are multifactorial, and I just listed some of the reasons for them on the slide, but I want to really focus on things like socioeconomic status and social class behaviors, I think we all know about, but really that there's a lot of biology involved in this, and that's something new that I think that we've been learning. We just had a very lively discussion with a group of students, part of which was about the role that healthcare plays in relative contrast to some of these other factors. This is actually a picture of the determinants of health and just a picture of how all this fits together, actually taken from Healthy People 2010, just to remind us that the individual sits in the context of their physical and their social environment. They're influenced and influence both biology and behavior. And sort of around that individual context are things like access to quality health care and all the kinds of policies and interventions that change our environment, that enable public health, et cetera. This is another way of thinking about this very complex web of causation, and one of many kinds of diagrams that help us think about how it is that health is generated. Again, here we see a pretty substantial emphasis on socioeconomic factors, education, income, appreciating much more now the role of place, the neighborhood, the fact that where you live and what the circumstances are around you plays an important role, as does the individual circumstance. I think we all know about a number of the behavioral factors again, and we know more and more that there are a lot of psychosocial factors involved, whether they're experiential factors or social factors. Healthcare, none of us dispute, plays a really important role, but somehow all of this ultimately influences our biology in ways that ultimately influence our physical, mental, emotional health and are manifest in health outcomes like morbidity and mortality. I think that lots of times, particularly in public health, we like to forget that healthcare plays a role at all. We like to ignore the fact that the big bad healthcare system over there has something to do with it all. But more than we like to forget or ignore healthcare, we like to forget or ignore that there's really a biological component to all of this that needs to get addressed. And you know, our biology is changing all the time, whether it's through aging, whether it's through response to stress, whether it's through response to environment. But ultimately, that pathway becomes critically important here. Social stressors and all of these environmental factors impact our biology beginning in early life. And that's something that I really want you to have as a take-home message from tonight. A lot of this really begins in early life. And if we want to influence the trajectory of health in our country or in the world, we have to really think about how to influence that in early life. And whether it's income in early life, education in early life, and particularly of our mothers, the neighborhoods we grew up in early life, the opportunities we were born with and the adversities we face in early life, occupation, all of those things have influences in early life. So this biological embedding, it occurs really, really early in life. And in our session the last hour with the students, we were just talking about the role that income plays in life expectancy. And none of us dispute that at all. It turns out that this, again, is going to be all translated through biology. So this is a slide taken from work of my colleague Teresa Seaman, looking at hemoglobin A1C, which is a measure of glucose control. And it's usually a measure that you're familiar with as of blood sugar control for diabetics, but everybody has a hemoglobin A1C, and it's higher in some people than others, even within the normal spectrum. And what you see here is that the red area are people who are in the lowest poverty, have the lowest poverty income ratio, so they're going to be the poorest, and we go up through socioeconomic strata over time. And what you see is, regardless of how old you are, even age 0 to 5, people in those poorest groups, age 6 to 10, have much higher, they're in the top quartile or the top quintile of the hemoglobin A1C or glycohemoglobin ratio. Yeah?
Does that correspond to obesity?
Not necessarily in early childhood. It gets manifest more as you go up, as you go up further in age. And certainly poorer kids we're learning more and more, are more likely to be obese. But independent of that, they have high, and this is a subclinical threshold, okay? And so you can see within here, there are pretty impressive income gradients, and you see them become clearer as those income gradients as people get older. It's also no surprise, I think, to any of us that people who are at the lower income end of the spectrum perceive more life stress, okay? And so this is just looking at that income gradient with regard to what people report as life stress. And you say, well, this is just perception, you know? Poor people, you know, are disadvantaged and they just perceive that they have it worse off. It also turns out, if you try to quantify the kinds of life stressors that people experience, that perception and reality match up pretty well. So people living in poverty as opposed to people of middle income are much more likely to have housing problems, to have family turmoil, kids experience family separation, and this is all about kids and kids experiencing violence in the home. So this perception and reality match up, and poor people have a lot more of these kinds of adversities and stressors in their lives. We also see that that kind of disadvantage really disproportionately affects people in certain racial groups, racial ethnic groups. And this is a slide taken from Dolores Acevedo Garcia's work, looking at the kinds of life opportunities children are born into in inner city Chicago. And what you see here is that, like 90% of white children are born into neighborhoods that are not in poverty, that are in the richest distribution of the poverty income. What you see, if you look at this, is that look at the difference in that distribution for white and black kids in Chicago. So this is at birth, black kids being born into much more stressful environments, neighborhoods with much higher rates of poverty. So it's something like over 80% of African American children born in this country are born into circumstances that the worst off 5% of whites are born into. This is in urban environments. Now you say, well, if you look around here, most people are white and many, many, many people are poor, and that's true. So, but this is a urban example of that. And you see that again, here it is, the same for Latino children. Here a little more than 2/3 are born into poorer neighborhoods than the worst off 5% of whites. So again, you say, well, I'm still not so convinced that this is a bad thing. So I'm gonna spend a little more time trying to convince you. This is a slide that looks again at how we think some of this biological translation happens. And this looks at people who were these low, low, low now, and high, high have to do with people born into poverty, people who are now in poverty, people who are on that high now, people who were born into non-high income circumstances, and people who are born into high income circumstances and stay in high income circumstances, okay? And what you see is there's a gradient here again in what are called their cortisol levels. So for people who aren't familiar with these, cortisol is a stress hormone that your body makes, and it has a variation in level throughout the day, okay? And that's normal. The more up and active and stressed you are, the higher your cortisol is going to be. It's also involved in that fight or flight response. But at resting at night, okay, when it's lower, those cortisol levels ought to come back to a really low level. And what you see is that that doesn't happen. So people who are born poor and stay poor, they have the highest levels of nocturnal cortisol, okay? People who were born into high-income circumstances and continue to live in high-income circumstances, they have the healthiest cortisol profile, okay? And you see that gradient in the middle. So there's something else going on here that we need to get a much better understanding of. Most of what happens, we believe, happens in the first 3 years of life. And this just is another slide that tries to drive that point home. Looking at the number of risk factors that a kid is exposed to in the first 3 years of life. So those stressors that I talked about, family separation, violence, etc. Add up those number of risk factors and look at the relationship between that and developmental delays. So from age 0 to 3, the more of those kind of stressful circumstances and risk factors you're exposed to, the greater your chance are of having a developmental delay. This biology gets hardwired really early in life, so that by the time you're 3 years old, there may be a substantial chunk of this that you can't overcome by changing somebody's environment, that you can't overcome by throwing all the educational resources of the world at them, by giving them good diet, by all the preventive care in the world. There's something that gets hardwired in here. And so we have to pay a lot more attention, I think, than we have been to what happens early on in the life course. So where you live affects your biology. This is work done by my own team at RAND that looks here, not an individual socioeconomic position, but neighborhood socioeconomic status, okay? Looking at how many standard deviations out from the mean is the neighborhood, the socioeconomic status of the neighborhood you go into. So over to the left, poor neighborhoods, over to the right, well-off neighborhoods. What's on the y-axis is a concept called allostatic load, which is an index of cumulative measures of biological stress. So think about things like blood pressure and cortisol and markers of inflammation. All those things sum up into an index. And what you see, controlling for an individual's income and education, is that the socioeconomic status of the neighborhood they live in is associated in a pretty direct way with their allostatic load. So again, poor neighborhoods, bad biology. The other really interesting thing to me about this slide is these parallel lines. So what you see are two things here. What you see is that blacks and Native Americans Mexican Americans across that whole income spectrum have a higher level of allostatic load. But neighborhood socioeconomic status influences all of them the same way. Those slopes of those lines are parallel. Okay, they're all the same. So no matter what race or ethnicity you are, living in a poor neighborhood is bad for you. Okay, independent of your own income, education, etc. Next slide. So here for me is the hardest part. And that's the kinds of experiences and exposures that you have influence genes. Now, influence your genes. Now, when I went to medical school, we learned that, you got the genes that you inherited, and that was it. Okay? And you pass some portion of those on to your kids, and biology is destiny. Well, I think we are learning that biology isn't really destiny. So there are these modifications to genes called epigenetic modifications. And they are changes in the way genes are expressed that are caused by changes other than the underlying DNA structure, that ACTG building blocks of DNA, okay? And some of the biological mechanisms, for those of you who are more biologically inclined, are listed here: methylation, histone modification, chromatin remodeling, all these microRNA changes, et cetera. Okay? And what we see is that these epigenetic changes occur in animals and humans and across a whole wide range of issues, whether it's maternal behavior, caring for children, and animals. Lots of animal models that look at things like licking and grooming, okay? In cancer, we see both in animals and in humans that people living in stressful, low-income, disadvantaged environment have all of these different changes in the DNA that are in their cancer tissue. In asthma, the same thing happens. So this is making us have to think fundamentally differently about how we think about biology as destiny, the genetics that we're born with, but also how life circumstances and life environments are going to influence our health outcomes. And for me, the most amazing part is that these changes, at least in animals, have been shown to be transmitted intergenerationally. So if you take a mother rat, for example, who is genetically bred to take care of her kids, and you expose her to a really deprived environment, she'll not only stop taking care of her kids, but her offspring won't take care of their kids as much either. Okay? So when we start to think about how are we going to intervene in these kinds of cycles, it gets much more complicated than we in public health or medicine were ever trained to believe. Ultimately, these things manifest themselves in all different kinds of ways in inequalities in outcomes, whether it's disease incidence, whether it's prevalence, whether it's mortality. And I just put this up here so you can, just one random example of a disease, it almost doesn't matter what disease you look at, many of the patterns look like this. This is taken from some work done by some of my colleagues at Ohio State University, and so just to convince you that it's not only a phenomenon of whites versus other racial ethnic groups, we also see lots of variation in outcomes, and I think you know this, and in screening behavior and in cancer health behaviors among whites. And this just compares whites in Appalachian Ohio with whites in non-Appalachian Ohio. The thing that I think is really interesting about this work is not only the way that we think it reflects issues like poverty amongst whites in different parts of the state, but that this group is beginning to understand that there's such a thing as an Appalachian identity, like there may be a Hispanic identity, or for some African Americans, an African American identity, or for me, a Jewish identity, or for whatever it is. Appalachian whites who identify as Appalachian have fundamentally different health behaviors and health outcomes and biology than do Appalachian whites who don't identify themselves as Appalachian. So I think people are still trying to get their hands around what this means and how it manifests itself. But I think it is a topic really worthy of further exploration. The other message that I want to leave you with is that not all disparities are worse for minorities of any different kinds. And this just looks, for example, at other lung disease, chronic bronchitis and emphysema among whites and African Americans. And you can see, largely because of differences in smoking over time, that COPD or lung disease prevalence rates are higher in whites than in African Americans. So that's the biology part. Turns out there is a healthcare system part of this as well, and that we know that the healthcare system treats people unequally. And we know that the healthcare system treats people unequally when it comes to access to care, to quality of care, to all kinds of stereotyping and discrimination, whether it's about race, whether it's about weight. I can remember actually during the time I was working with Randy, I was having this conversation with my son who asked me if he thought people who had mental illness got discriminated against in the healthcare system. And I said, well, probably. I said, so what do you think gets you discriminated against in the healthcare system? And he said, being black, being overweight, acting mentally ill, and having bad teeth. So stereotyping can occur in all kinds of different ways. And you know, he picked on one that I hadn't really thought about. And the other thing is that the healthcare system doesn't really own very well the fact that it treats people differently. So these kinds of inequalities occur at every step of the way in the healthcare system, and I'm not going to go into lots of gory details about this. We know that but I'll provide some data to show you what goes on this very simplified schematic along the way. We know that rates of uninsurance differ by race. Hispanics in this country are the least likely to be insured. And we know that access to care in general, even once you're insured, frankly, differs by both race and by income. So these are slides that are taken from the National Health Disparities Report, which was put out by AHRQ. And you can see it compares on a whole bunch of different measures, access to care for blacks versus whites, Asians versus whites, et cetera, different racial and ethnic groups, and then poor versus non-poor. So you can see, and the way to interpret all of these slides is you can see in the first bar on the left, that blue is on 67% of measures, blacks and whites access to care is the same, but on 33% of measures, they're worse, okay? Look at poor and non-poor, 100% of measures, they're worse. Look at Hispanics and not, 83% of those measures are worse. Look at Asians, okay? They're actually better. The only group, but they're better on access to care 17% of the time. Not surprisingly, even if you have access to care and you have health insurance, there are pretty big differences in whether you get a regular doctor. Again, you can see blacks and Hispanics are less likely to have a regular doctor than are whites. But we also know that beyond that, people really have different perceptions of how they're treated in the healthcare system. And you can see that in general, minorities in this country perceive that they would have had different care if they were a different race or ethnicity. I would dare say, based on Electra's work, that Appalachian whites perceive that they would have different care if they thought they were not Appalachian. That's probably true. But it's not just the healthcare system that produces this really different point of view. I think we know, and I think the election of our president has sort of catapulted a lot of this, you know, front and center, that people have really different perceptions of things by different race and ethnic group. And so you can see in the workplace, you know, far fewer whites and blacks or Latinos say that racism is a problem. In housing, in education, and in healthcare, you have that phenomenon across all of society. Actually, in some sense, a little less in healthcare than in other aspects of society, but here we really focus on the healthcare system. And once we get into the healthcare system and we get into the doctor's office, one of the problems is the doctors don't own this problem either. And so this is actually work taken from some stuff I did with some other colleagues in which we talked to cardiologists, because disparities in cardiovascular care have been the ones that have been the most documented. And we asked them whether or not they believed that similar patients clinically receive different care based on their race and ethnicity, regardless of other factors. And it was kind of interesting. Only about a third of cardiologists and only about a quarter of cardiovascular surgeons believe that in the healthcare system in general that this was true, which is a pretty low number given the thousands of articles that have been written about this. But I want to point out this sort of ownership issue. If you say, well, even among those people, well, it's a problem in our society. How about in your hospital or your clinic? Okay, there you get only 12% of cardiologists and only about 4% of surgeons telling you they think it's a problem. And then if you say, well, what about in the patients that you treat? Hardly any doctors think that this is a problem they have. It's somebody else's, but it's not mine. And we as health professionals need to own this issue and figure out why it occurs and what we do about it. Well, one of the reasons it occurs, and one of the reasons some of these disparities exist, are probably rooted in factors that are well outside of the healthcare system. And one of those is probably racial segregation and for income segregation. So this is a slide that looks at who in America, what the distribution of doctors in America that take care of African American patients. And basically what it tells us is that about 20% of doctors take care of about 80% of blacks in this country, okay? And if those doctors are surveyed, what you find out is that they tell you that disproportionately they have trouble getting resources for their patients. They have trouble getting consults, diagnostic tests, laboratory tests, all of those kinds of things. Probably partly because of insurance and how they're clustered, but partly because of where it is that people live, getting back to that issue of place, okay? And that doctors tend to cluster, where there's people with money and people with health insurance. And here's an example of that, again, taken from our own work in Washington, D.C. Washington, D.C. is divided up into a bunch of different what are called wards, and there's always been a divide between this side of the river and that side of the river in terms of income and in terms of race. But this is a map that just looks at the chronic disease burden in Washington, and you can see the chronic disease burden in this area is really high. These red dots are where primary care providers are for adults. Well, it doesn't really look like the distribution of primary care providers has very much to do with an underlying population need. Doesn't, not only an issue for primary care, but also an issue for specialty care. And this is a slide of just prostate cancer incidence. And the reason I use that is because I talk to people in the city council a lot, and only one of them is a woman. And so the guys on the council take this much more seriously than they would if I put up the same slide looking at breast cancer and oncologists. But again, you can see you've got this area where prostate cancer incidence is really high. There's no urologists over here at all. So the doctors that treat this problem are non-existent. So the quality of care people get on lots and lots of different measures also varies by race and ethnicity. So we've got insurance status, we have access to care, we have regular source of care, we got primary and specialty care, and then we have all these aggregate measures of quality. And these things look about the same kinds of patterns as the other things that I showed you. You know, in lots of measures for blacks versus whites, 3/4 of the time it's the same, but 18% of, it's worse, I'm sorry. 18% of the time it's the same, and a very few percent of the time it's better. If you go all the way over to that slide in these patterns, I'll tell the same story, that here, high and low, poor people, almost 3/4 of the time, get worse care than non-poor people. And this is just one other slide going back to those issues in cardiovascular care. And I only like this slide because it goes through a whole bunch of studies and lays out sort of the odds ratios of getting better or worse care. So the stuff to the left of that blue line are studies that show, in this case, that African Americans get heart surgery at rates that are lower than whites. And it's not anything about heart surgery or even about African Americans, just to show you the consistency of the findings about disparities. And then we start to dig in again to some of the reasons why that is, okay? And just like I told you, that there aren't primary care doctors, and there aren't necessarily specialists, we also see then some other kinds of things that happen. That this is a slide looking at survivorship for people who have early stage lung cancer, and we see that it's better, not by a lot, but it's better for whites than it is for blacks. And you start to decompose why that is, and what you see is that it has to do, by and large, with who gets surgery and who doesn't. Okay? If you looked in kidney disease, you would find the same thing about who gets transplanted and who doesn't. When you look at that, and there's been a lot of work, let's say, in the kidney transplant literature, if you say to doctors, why is it that these people haven't been put on a transplant list or had kidney transplants, they'll say, oh, it's about patient choice. They don't want to have a transplant. If you talk to the patients, okay, patients say, I haven't ever been offered, nobody's ever talked to me about a kidney transplant or told me what it was. Now that you tell me, it's a pretty attractive option, okay? So the doctors and the patients have pretty different perceptions of what's going on, but about 3% of the difference, and only 3% of the difference, is explained by choice, whereas most health professionals think that about 80% of the difference is explained by choice, okay? Another thing I sort of wanted to highlight, just as we talked about differences between Appalachian and non-Appalachian whites, none of these groups are monolithic at all. And the subgroup differences within them are as important as anything else. So for example, if you just look for a minute at whites versus Hispanics and asthma mortality, just as an example, what you see in those 4 bars to the right are non-Hispanic blacks, I guess all Hispanics, Puerto Ricans, and Mexicans. And you can see that ethnic group and sort of subgroup within this accounts for quite a lot of the variation. You see the same thing in a lot of ways in a lot of Asian subgroups. There's been a lot of recent data to suggest that if we could improve quality of care, we can reduce disparities. And we don't know yet about disparities in outcomes like mortality, but we like to think and we hope that if we improve quality of care, at least we can get to reducing disparities in some of these intermediate outcomes. So this top graph looks at what's happened over time. You know, actually since, you know, health plans and others have had to report on the quality of their care. And what you see, and this is an example of diabetes care, is that the process of care measures, did you have your blood checked, did you have your feet checked, did you have your eyes checked, all of those things. The disparities between whites and blacks in this case, because that's where most of the data are getting to be less. The real kicker is that the disparities in these intermediate outcomes, was your sugar controlled, were your lipids controlled, we're not there yet. So improving the process of care alone, i.e. getting all these tests done, doesn't necessarily yet translate into even improving intermediate outcomes of care, let alone long-term outcomes of care. There's been, this is work much more recently done in community health centers that tells us a little bit the same thing. There's been a huge effort in community health centers all over the country to try to address disparities in care. And what we see, whether it's in asthma, or diabetes, hypertension, HIV/AIDS care, it doesn't matter what it is, that you can improve these processes of care. We don't yet improve any of the measures of disease control. And that's pretty discouraging. Makes me think that we need to look in part outside the healthcare system. If I think about it, and you think about it, most people with a chronic disease, and certainly any one of these chronic diseases, almost at most, they're in a doctor's office maybe 4 times a year for at most a 15-minute office visit. So that's 1 hour of every year that they encounter the healthcare system. The rest of the time, they're at work, they're in their neighborhoods, they're with their families, but they're not really encountering and largely not thinking about the healthcare system. And so it really brought me and others to thinking about, well, how do we think about this differently? And in whose interest is it to get us to health equity? And how do we start to mobilize all of the different factors around this? So there's a role for basic science research trying to figure out this biological part. There's a role for business in here, creating healthy workplaces and incentives for people to stay healthy. There's a pretty big role for community and public health, and you're all in a school of public health. I think you know your role, at least in part. And then there's this role for healthcare providers and health plans and the healthcare system, as it were, and all those groups have to come together to get us to a point of health equity. Interestingly, in this time that we've had this increased awareness of disparities, one of the groups that's really come to the table to think about inequalities or disparities has been the business sector. Why? Well, a couple of reasons. One is that there have been really dramatic changes in workforce demographics. Premium costs are rising. Often productivity is down. And one of the things that a lot of these businesses started saying is, well, gosh, when it comes to racial and ethnic disparities, I'm paying the same dollar premium for everybody, and I'm getting only half of what I pay for a good chunk of my population. And from a business perspective, that's not a good deal. And then on top of that, if people have worse health outcomes and they're not at work, that really has pretty big impact on my bottom line. And so we're starting to see, in so many ways, much more activated employers on this. They, in turn, have been leading on health plans and saying, so what is it that you guys, that we buy health insurance from you, what are you guys doing about this issue, and what are you guys doing about health disparities? That kind of pressure led to this thing called the National Health Plan Collaborative, which was a group of about 11 now 12 large health insurers and about 90 million members around the country to come together in kind of a public-private partnership to think about, well, what might they do around disparities. So this is the healthcare system again, but you'll see it's going to have to reach outside to be effective. So what did they have to do in order to be effective here? First, they had to convince themselves that they had disparities. Okay, just like doctors didn't believe it, these health insurers said, everybody's insured. We can't have disparities in our plan. So first, in this case, they got information about the race and ethnicity of their enrollees. Believe it or not, the healthcare system hardly has any data like that, just like they hardly have any data about the income of their enrollees. So you couldn't do this kind of work yet with income. Then what they did is they took the data on race and ethnicity and linked it to their measures of quality of care. And guess what? They had disparities. And once they identified they had disparities, then they had to say, okay, now we have an obligation to do something about it. What are we going to do? And so they started targeting and testing interventions. And it was interesting because these plans were all competitors. And they pretty much said, we'll compete for market share, but figuring out what works to solve these health problems isn't something that we're going to compete about. And so they have shared and disseminated a lot of the information about the kinds of things they've tried. I think they've been learning that it's as important to share what doesn't work as what does work. But that's where they've been. They've done, I think, some pretty interesting work along the way that has actually been helping at least me think somewhat differently about some of the approaches to these health disparities. So this is data taken from a health plan in Northern California. And these dots represent all of their diabetic patients. And you see they're spread out all over the Bay Area. And the colored dots represent whether or not they had their lipids checked, okay? And if you said, gee, I want to do an intervention to get people to get their lipids checked or their lipids in, you'd have to do this whole region. So they said, well, what if we just wanted to look at parts of this area where people are clustered who haven't had their lipids checked? And so these are areas where 2/3 of people in a given census tract haven't had their lipids checked. And pretty soon, this problem becomes smaller and a little bit more manageable. And in the next slide, the health plan said, what we really want to do is an intervention with Hispanics, because diabetes is really prevalent and we want to work at lipid control here. And next thing you know, they got 5 census tracts that they need to focus on. This is kind of a population health approach to care. And although health plans think they take a population approach, as we think we do in public health, sometimes we say X% of men and Y% of women have this, X% of blacks and Y% of Hispanics and Z% of whites have this. We don't often think about it in these terms. And if we do, we say, gee, one county is more affected by the other because public health collects data at the county level, but doesn't usually get under that county level to figure out much of what's going on. This is data taken from another plan, and this is an area of Los Angeles where you see a similar thing happening. But here, you see that there's this area over here where on multiple measures of diabetes care quality is really crummy. And so we started asking ourselves, why was that? And so we took this area, this is the same area blown up, and this is here now just lipid testing. We said, first thing we said is this must be a really poor area, our own stereotyping of the situation. Here's the poverty map of that area. Okay, it doesn't look like it has much relationship to these census tracts where people aren't getting their lipids tested. Then we said, well, what about thinking about the tracts that are linguistically isolated? Okay, and suddenly you start to see that that has a lot more resemblance to this, colors notwithstanding, than this does. And you say, well, gee, if I wanted to think about doing an intervention, maybe I ought to do a language intervention, at least for starters. Before we did this health plan thought it was going to send close to 1 million mailings to people with Hispanic surnames, suggesting they got their lipids checked. We said, you know, that's probably not a very efficient use of resources. Not everybody needs a mailing in Spanish to do this. But in fact, why don't you just focus your resources here, provide people education in a language they can understand, and access to care and clinical encounters in a language they can understand, and see if you can deal with the problem in a better way. Doing stuff like this obviously enabled them to say, okay, if I wanted to go to a clinical site of care, I'm going to go to where most patients go. So the thicker lines show you the care system sites that more patients go to. So if I was going to start by working in this area and doing an intervention in a clinical area, I would go here, then I would go here, then I would go here. So it's a population approach within the health system to taking care of, to addressing problems like this. More recently, we've said to ourselves, well, what if we could do this with health literacy? Some of the health plans did a lot of focus groups with diabetics who had poor quality care, and one of the things that it really came down to was this issue of health literacy. I think a big issue in this geographic area as well. So health literacy is the ability to read, understand, and act on health information. And so we said, well, gee, maybe we could figure out how to map health literacy, and if we could identify those hot spots for low health literacy, then maybe in addition to looking at poverty and linguistic isolation, we could actually figure out where we need to do interventions that attack the health literacy part of the problem. And so we've just finished doing this in the state of Missouri, and you can see these hot spots of low literacy. I don't know if the next slide has hot spots of low literacy on it too. No. But people say, why Missouri? Because it was actually a local foundation in Missouri that gave us the support to do it at a time when nobody else was interested. But now we have the technology and the methodology to do this kind of mapping for the country. And again, you can't afford to send community health workers everywhere. You can't afford, let's say, an intervention where you pay a pharmacist to spend more time with a patient, helping them understand how to take their medicines and be adherent. The system can't right now, or thinks it can't afford to do that everywhere. But you could focus on those low literacy areas and potentially make a pretty big difference. If you wanted to focus interventions at the provider level, which is sort of what health plans really want to do, you can do it using some of these ideas and tools. So this is an area in California that's largely limited English proficiency, and all these dots again represent their patients with diabetes. And so they did some provider profiling in this area. And here is the quality profile for provider A, because you know that now that health insurers are profiling providers and either paying for performance or penalizing providers with crummy performance. Most people prefer, I think they prefer the pay for provider approach. So they said to provider A, you're not doing so well. And provider A's retort was, well, you can't hold me accountable for the people who live in here because they're harder to serve. You know, I don't speak English. A lot of people come from this area, don't speak English. I mean, I don't speak Spanish. A lot of people come from this area, don't speak English. And it's not my fault that I'm their provider. You can't hold me accountable for the quality of care that I provide. And if you look at the patients I take care of outside this hotspot, my quality of care is much better. It's even better than the national average, which is pathetic that you think that getting 2/3 of the care you're supposed to get is better than the national average, but it is. So don't hold me accountable here. Well, along comes this health plan and they look at provider B. Provider B takes care of patients that live in the identical area. And guess what? Provider B has really good quality scores, both outside that hotspot and inside that hotspot. So the health plan says to provider A, this year we're going to give you a break. You go talk to provider B, figure out what it is that they're doing, and decide if you want to start doing it. And we'll support you to do that. We think your quality of care will be better. So these tools can be used in sort of this public health approach to the medical care system can be used in lots of different and interesting ways. This, for me, is the ultimate kicker in this, and where I think we in public health completely missed the boat by dissing the healthcare system. So this is a picture of an area of Denver, and these red spots, these red areas, are where people's diabetes control is really crummy. Well, before anybody had a map of diabetes control for Denver, the Denver community, the public health community, a bunch of people got together and said, you know, diabetes and obesity are a really big problem. Let's put some diet and exercise interventions in place in Denver. And so these blue bordered areas are where they decided to situate those interventions. How do disparities happen? How do they get perpetuated? We have a pretty big mismatch between the public health response to this epidemic and what the burden is. Now, why did this happen? Well, I would posit that one of the reasons this happened is because this community was a little better off and was better able to write a good grant proposal, as was this one. This community, you know, other communities had trouble. So I think public health can have more tools at its disposal to use. And I think if public health would figure out how to play with the healthcare system a little bit, and the healthcare system would decide to play with public health and think about its disparities in its health challenges and some other population terms, that we could probably all do a better job. One of my hopes is that maps can start to serve a little bit as a universal language and help people talk to each other better. They can also help communities get more involved, because if you saw that you lived in this community, you know, you'd want to say, so why is my community red? What is it that's wrong with my community? Why is it a hot spot? And what might I be able to do about it? There is hope. And I just wanted to highlight, you know, one of the national initiatives that has been trying to address disparities, and this is a program called REACH, which is run out of CDC. I don't know how many of you are familiar with it, but it is a program that has been really working to address disparities around the country in a number of clinical areas. And after being at this for a while, it doesn't happen overnight, they're actually being able to show some results which I think are pretty encouraging. So the top panel was results from REACH sites that worked on trying to do lipid control. And what you see is these REACH sites started out at the same place for African Americans as others, and well below national comparisons. And these REACH communities now have pulled ahead. You see the same kind of thing for American Indians taking blood pressure medicine. They started out way behind. They're pretty down and out communities. They, by this time, are ahead. They're not yet up to the National BRFSS standard, but they're making progress. So this gives me hope and a cause for optimism that we can attack some of these problems. Now, what's different about these kind of interventions? What's different about these kind of interventions is that they're community-based. They required a community-based organization to partner with a data partner, either a health department or a university. They started to address social and economic conditions in the community. They built trust with the community. They did interventions that educated people, helped people navigate in the community, and dealt simultaneously with some of these health issues, getting people to take their medicines. At the same time, they did a whole set of psychosocial factors and other community interventions. So let me end with just thinking with you a little bit about what kinds of policies are likely to impact on the kinds of inequalities we see and we've talked about, whether they're inequalities in socioeconomic status or inequalities that are associated with race and ethnicity. First on my list is investments in early childhood, without a doubt. I think we know enough now to think that what happens in early childhood hardwires you for life. And that not all of it is stuff that we can undo. Certainly we know that education is a fundamental determinant of health, and so some of those investments ought to be in early childhood education and in equalizing educational opportunities, probably for all children in this country. We were talking about this a little bit in the group before this talk, and I was saying if I look at the economic stimulus package and look at what's in there, there's this big chunk of money for education. In my mind, that's an investment of health and in the future health of our country. Certainly improving environmental conditions of all kinds, terribly important. Even old data suggests that if we could reduce air pollution, we would reduce Medicare expenditures by 7%. We have this gigantic crisis in healthcare costs. We very, very rarely think about improving air quality as a way to improve healthcare costs. But we ought to think about all these things as being really tied together. So improving environmental conditions, improving neighborhood disadvantage of the kinds we talked about, and then using these healthcare system levers, expanding health insurance, improving quality of care, and probably monitoring quality of care for subgroups, thinking differently about payment reform. And then I think we really need to think much differently about strengthening the science. And again, we in public health go nuts when people want to invest in science and in basic science. We have to think about how we marry our agenda with those of basic scientists, how we think about what are the pathways through this happen, and how then we think about, well, what are the effective public health interventions that disrupt these pathways and disrupt these patterns and make us go forward. And certainly improving the science of what we do in public health and the practice of public health is going to be critical in this. And there I think, we need new tools at our disposal, sending out leaflets and putting up signs. We know that this stuff doesn't work, and we got to start trying some different kinds of things. So I just want to leave you with this cartoon, which summarizes, I think, a lot of the points that I wanted to make here. It says, "Hi Shirley, what's going on?" It's Bo McBride Jr. His mom brought him into the emergency room about an hour ago. Bo had a serious asthma attack, but his mom says you treated him today. So what's wrong? Why didn't Bo get better? Next slide. Yeah, I gave her everything needed in case of an attack. She apparently got confused. Miss McBride can't read. Okay, so it all gets back to these fundamental determinants of education, opportunity, things that happen in early childhood as we think about solving some of these problems. So let me leave you here. I'm really excited to entertain some questions and comments.
I noticed that you didn't put anything in there about gender disparities. Do those exist, and how important are they?
Good question. Gender disparities do exist. I just couldn't do everything all in one talk very easily. We know a couple things. We know that by and large, men have worse health than women, and men have shorter life expectancies than women. We know when we look at the healthcare system, in some areas like cardiovascular care, women get less care or worse care than men. So we have this little bit of a paradox. And we know that in other areas, relative to men, women may receive less aggressive care. We also have some interesting emerging data coming from our own neighborhood work. And now in two separate studies, one of the things we found is that these neighborhood effects on health are different for men and for women. And the characteristics that are associated with neighborhood disadvantage operate differently for men and for women, which has made me really want to think very carefully about sort of what are the public policy solutions to this, because if we start talking about neighborhood redesign and the way it is that people cluster and the way it is that people live, we may think we're making things better for everybody, and we may not be. And so we have to, as we go forward, we have to think not only about these income and education differentials and the race ethnicity differentials, but also some of the gender differentials going forward. I think for a long, long time, at least the past 2 decades, women's health has been really on the horizon, and a lot of focus on studying health needs of women and thinking about how to equalize care. for men and women. I think men have been left way behind in this. This is my own view, and a lot of my colleagues would disagree with me. Not that we need a field of men's health to parallel women's health, but we need to reconceptualize this maybe as a gender and health issue, and how to think differently about the different needs of different populations, and the kinds of public health approaches. I suspect that men and women respond differently to the kinds of public health interventions that we typically do, as well as to some of the healthcare interventions that we typically do. So I think it's an interesting field for more work and study.
My name's Jennifer Hovater, and I'm an advocate for lymphedema. And I was wanting to know what we could do for the diversity, like for the doctors. Why can't we get a lymphologist in Johnson City? This area is so far behind in the treatment for lymphedema. A lot of lymphedema patients are not getting diagnosed. They may have it, not know they have it. Doctors are not educated enough here to treat this, and we're trying to get a like a thing done where we can have them educated, have like a seminar, and also, you know, what can the community do here? What can we all do together, the public health and the community? What can we do to help lymphedema patients? And also, one more thing, tomorrow's National Lymphedema Day. I wish everybody would wear turquoise, support lymphedema patients.
Great.
Thank you.
Well, thanks. You know, you're raising a really interesting and complex problem. Lymphedema is a really difficult condition. And it's a very difficult condition to live with and a very difficult condition to treat. And there are a host of things that sort of are characterized as rare diseases that in some areas aren't so rare, in some areas are pretty common, and I'm not sure sort of how common it is here. But you know, the healthcare system as such, by and large, responds to market forces. And the market might not be the best way for us to deal with healthcare going forward. But you know, unless there's a way for a lymphologist to make a living here, it's going to be pretty hard to get a lymphedema specialist, I would imagine, to be here very much of the time. One of the things that I've been really impressed with has been a lot of the data a lot of the systems that have really taken advantage of new technologies in different kinds of ways. So even in Iraq, you see surgeons here guiding, you know, through computer technology and really sophisticated telehealth, guiding surgeries there that are life-saving. We have different ways of connecting people than we ever have had before. And I wonder if rather than having as your goal to get a lymphedema specialist here, that you work to identify the 10 best lymphedema specialists in the United States and think about how to have primary care people here work in a really different kind of working relationship with those kinds of people. I think that's the way of the future.
You mentioned very briefly about mental health and mental illness throughout the presentation. What role does mental illness diagnosis and treatment play into these procedures? And are you seeing that being more commonly accepted as having an effect on public health in general?
Well, I think the more we're at all of this, the more I think that people understand that sort of mental and behavioral health and physical health are pretty inseparable. We know that risk for the development of certain conditions is higher amongst people who are depressed, for example. We know that the outcomes for that are also worse amongst people that are depressed, and yet depression is a pretty stigmatizing disease. And so recognition for those kinds of things and access to care for those kinds of things are really hard. I mean, think about it, it's only this year that we had a mental health parity bill passed, right? That says that if you have health insurance, the health insurance plan has to provide the same benefits for mental health care as they do for physical health care. At the same time, we know that things like socioeconomic disadvantage and neighborhood disadvantage are associated with higher prevalence and incidence of many mental health conditions. And that those need to get dealt with. We know, for example, that the prevalence, if you control for other factors, that the prevalence of depression, for example, in African Americans and whites is about the same. The recognition of it is really different, okay? And the treatment of it's really, and access to treatment of it's really different. So we still have a really long way to go. For more serious and persistent mental illness, it's the same kind of thing. I think the more we start understanding more about this biology and how it changes your genes and how it gets transmitted, I think, you know, this field's about to just burst wide open, and I'm excited about that.
Could you comment, please, on disparities by diagnosis, the thought that perhaps a patient with a certain diagnosis might have trouble getting into the primary care system and that hospitals might readily accept patients who need a certain procedure or an expensive stay, whereas they might turn away elderly patients with simple things that would not require a procedure?
I think it's a great point. And so I think that those, certainly there are some diagnoses and some diseases that are really stigmatized and stigmatizing. And I'll just take HIV as one of them. That, you know, there are still doctors who don't want to take care of HIV positive patients. There are still hospitals that don't want to treat HIV positive patients, just as an example. And you see that in a whole lot of conditions. And some of that is about social stigma, some of it's about fear, some of it's about other stuff. There's a whole other set of things that have to do with the reimbursement system in our country and how healthcare is paid for and reimbursed. So hospitals are much happier to admit patients for elective procedures that pay a lot, open heart surgery, hip replacements, than they might be for other kinds of things. And in fact, many of them deliberately plan their emergency room flow and volumes so that they differentially, so that they can protect beds for those high-paying patients and they don't have to risk having, you know, low-paying patients clogging up those beds when they could be making money off them. Many hospitals have, and doctors have decided that Medicare doesn't pay well enough, so they don't want to take care of Medicare patients. So we got problems across this whole healthcare system. And yet, you know, there's that old adage that says the system is perfectly designed to get the results that it does. My own belief is without fundamental reform of that system, we're not going to address some of the kinds of problems that you and some of the other people have talked about.
Well, Nikki, thank you. Before you step down, we do have some parting gifts for you.
Oh, thank you.
Yeah. First of all, I'm sorry about the sound effect.
Well, thank you.
We're very pleased to bestow on you the status of honorary professor in the College of Public Health at East Tennessee State University. We believe you're the first one at Rand to receive this award.
Thank you, Randy. That's great.
But wait, there's more. For visiting us, we will give you also your own copy of the Encyclopedia of Appalachia. We're happy to mail it back home for you on your behalf, but there's a wealth of information there that will help put it into context.
That's great. Thank you.
But wait, there's more. A College of Public Health coffee mug that you can proudly display on your desk. And the most important gift is when we started this series, we wanted to do something that really reflected Appalachia and spoke to the unique qualities of this community. And as you know, this is an area that has had to make do with not very much, but has done it really, really well. And there's probably no better example of that than the quilt, which is little bits of cloth put together into something that's artistic and beautiful. And the wife of one of our faculty members has made, for each of our speakers, a unique art quilt.
Well, let's just hold this up for everybody.
That says on the back, presented to Nicole, Director of the Rand Center for Population Health and Disparities. Health and Disparities, what is the problem and what can we do?
Well, thank you. That's fabulous. Thank you so much.
Thank you, Nikki.